This is a good time to take a nap. This is my slide from 3 years ago when I did this talk at the American Society of Reproductive Medicine. So today it is going to be something up, down, there we go. This is going to be what I wish I knew when I did that talk. This has to do with data and analysis since that talk. I have no disclosures. I will talk about the focus on this is going to be on data. Studying it is like Donna Vogel said in 2000 at the NIH. It's like nailing jello to a tree. This comes and goes real quickly. We're not going to talk about the pain, neglect, confusion, all those things that go on with endometriosis. That list can be continued to more than 100 different problems that endometriosis patients have. We're not going to talk about all the hundreds or so of scientific challenges because those are all there. We're going to look at data. And some of that data, as you understand, is real squirrely. But we still have to look at all of that so we can decide where to go. This focus on specific concepts does not detract from the suffering of those with endometriosis after years of neglect. This focus to help us prepare to provide improved care. The concerns are, we talk about 10% of women have endometriosis as though that is an isolated number, right? But it's not an isolated number. And it doesn't include everything I've got there. It just talks about infertility and pain predominantly. There are a few patients who presented with swelling for ovarian cyst with neither pain nor infertility, but that number is a small minority. The big numbers are pain and infertility. You can take the numbers for anywhere from 3.4 to 82% for infertility, 3.7 to 86% for pain. So if you don't like my 5%, that's okay. I don't like them either, okay? It's hard to get numbers that we can believe. The numbers I'm using are because they fit what I saw in practice. So these are numbers that I believe are reasonable. Could we have other numbers? Of course we could. And when we look at that and look at all the ranges, we deal not only with those two 5%, but there's 5.8% in Fuente's article, and that top 5.8% who are asymptomatic in Fuente's article becomes 15% if you look at the focused figures in that one. So asymptomatic, or probably the better word is coincidental, because they weren't truly asymptomatic. Probably half of them had pain, probably 10% of them had severe pain. But they did the same thing that I did when I had my bilateral pulmonary emboli. I ignored my shortness of breath for the first 2 days and ignored and told my wife that I was just tired. Didn't explain to her why I couldn't walk more than 20 feet. So she finally caught on. She told my son, and within an hour I was in the emergency room. Okay? That's for shortness of breath in a 77-year-old male. When a woman comes in with her pain, with her menstrual pain and everything else, and tells her mother, you don't get the response I got from my wife, you get, yeah, that's normal. Right? That's the difference in normalization of pain like chest pain in old men and pelvic pain in young women. Chest pain in old men, you tell that to your son who's a physician, you go straight to the emergency room. If you tell that, if it's pelvic pain, you tell it to your mother, you get it's normal, so you get that thing. But what we do when we look at these concerns is we narrow down, we get to the point that we have about, and of that 10%, about 1% is truly non-responsive. Most everybody else we can treat with something. But that 1% is non-responsive, and if we look at that, that 1% represents about 1.7 million women in the United States. Okay, so we have 1.7 million women in the United States who are not going to respond to much of anything, so we need better answers for them. The 2% above that who respond to surgery, if you take the numbers down, it suggests that we need about 400. So if we define an expert as someone who does 100 cases a year, and we have 3.4 million women who need expert care, and that's divided over 40 years by 100, you end up with we need somewhere between 400 and 1,600 expert endometriosis surgeons. And if we go for more than that, if we try to train everybody, we will have no experts. Remember, the more people you have who can do surgery, the fewer cases they get and the fewer experts you have. So watch out for what you ask for on this one. You may not want more people trained, you just may want better access, and that gets us to this point. Almost 50% of women don't have access. And we have a major problem both in the United States and worldwide just in terms of access to care. If we look at the oh boy, what happened to my slide?
Same thing that happened to mine when the graphs went away.
This is interesting. 30 million women, 30 million people in the United States live in healthcare deserts. Don't have much access to anything. They travel 7 to 12 hours for care. 43% of working class adults had inadequate health insurance in 2022. 46% skipped or delayed care because of the cost. So we have not only a problem in terms of getting people who have adequate care, adequate money, and if you look at some of the people who have come in, like Padma Lakshmi, who takes 10 or 12 years to get a diagnosis, who's got access to everybody, all she has to do is go up to a physician and they will jump and try to help her. Okay? So you have not only that problem, but you also have problems that there are those women who will not have access to care, and men and other things. Then we get into people talk about repeat surgery. So that whole conversation this morning about what's management and what's treatment, I hate to tell everybody, and I don't care who it is, but no matter whether you call it treatment or management, it's irrelevant. We don't have good treatment or good management. And I think that if you're going to criticize one, you're going to criticize both, and you can use either words you want, but we have troubles. If we look at repeat surgery, and I hope this one doesn't scramble because there's going to be a lot of numbers, we have no definitive operation for endometriosis. I bring that up because I got slammed by the web trolls, okay? They thought I said we had one. I didn't say that. What I failed to say, it wasn't what I said, it's what I didn't say. I followed an ACOG speaker who said we had a definitive one. And what I should have done the minute I took over the speaker was disagree with him. I didn't disagree with him, I went straight to my talk and therefore implicitly agreed with him. We don't have a definitive operation. Anybody who heard that talk and understands the debate, I did not want to say that. I don't think I said that. I think what I failed to do was give you the negative. But let's talk about the negative today. Basically, our goals are going to be to treat symptoms and improve life for most women. If we look at the published cure rates, David Redline loved this slide. Talk about, remember, they're talking about outcomes. They're not talking about pain. They're talking about surgery, and you see endometriosis when you go back, and they are ignoring the fact that I have a paper that lasts 3 or 4 pages of just different ways we can miss endometriosis and laparoscopy. That was this thing back here, if you want to read it. Go to endometriosisconcepts.com and you'll find it. It's in there. So this is surgery. If we look specifically at the papers that we have, the paper by Federley in Italy showed that the reoperation or GnRH treatment in young patients was 54% down to 0 at 35. But if instead of looking at severe pain, if you look at just recurrence of pain coming back to seeing patients, then the numbers jump. In the 31, 35 range, it jumped by 3-fold. If we take that and look at the Ontario Health Database, 84,000 patients, 43 laparoscopies, 23,000 hysterectomies. They divided that into 6 different groups. We're going to look at 3 of them. We're going to look at diagnostic laparoscopy and therapeutic laparoscopy without BSO, because if you take out the ovaries, almost nobody has surgery. And we're going to look at hysterectomy with BSO, which is supposed to be definitive. And we're going to look at those in these 3 groups. Remember that asterisk means that they preserve the ovaries. So therapeutic laparoscopy, preservation. The disclaimer in the beginning, remember, this is throwing all physicians together. If you look at Stahl's data, at the 25th percentile, once a patient can get to a gynecologist, it takes them a month to make the diagnosis. 25% of gynecologists. At the 50th percentile, it's 5 months. At the 75th percentile, it's 32 months. Their average delay to diagnosis was 8.3 years. The family physicians, all the people in between the patients and physicians, who held it up the most. Patients held themselves up somewhat because of the same reason I talked about earlier. Everybody normalizes their pain. Okay? Even crazy people like me and my brother with his thromboembolism up in St. Louis, he drove to Atlanta so he could see a surgeon in Georgia. Well, Missouri is the Yankees. We won't. So we're going to look at their database. If you only look at repeat surgery, then hysterectomies look good. 0.4% compared to 24%. Note that 24% for diagnostic laparoscopy means that 75.8% of women who had a diagnostic laparoscopy only did not have more surgery. That suggests that either several things. One is, with the diagnosis, the patient can handle it better. Two is, with the diagnosis, the physician can handle it better. Three is, our data is a piece of trash and you go to find better data. Okay? Take your choice. Probably others I'm not going to talk about. But if you look at the ER visits for pain, then hysterectomy doesn't look so good. There's only a 7% difference between laparoscopies and hysterectomy in terms of repeat visits for pain. Okay? And if you look at any visit for pain, it gets even worse. There's only a 5% difference. So in terms of coding for pain, diagnostic and therapeutic laparoscopies were fairly equivalent, and hysterectomy was only about 5% better. So if you're looking at pain instead of repeat surgery rates, we don't do so well. That's the reason for those. If you watch the web, everybody's unhappy about Andrew Horn's study. Andrew Horn, Lucy Whitaker, and Scott McKenzie, and a whole bunch of others. If you haven't read the whole list, you see my name on there somewhere. There are three of us at my level who are the blinded reviewers for the surgery. So I'm a blinded reviewer in that study. The other two are at my level. So Andrew has gone in there and decided they have a 3-arm study. They have excision, coagulation, or laser ablation, depends on the preferences of the surgeon, and a no treatment arm. How in the world they have now had 500 plus patients who signed the permit? How they get 500 patients to sign a permit that says they're not going to treat them is beyond me, but so far they've done it. So we're waiting to see if they can show any difference in that study. If we look at reoperation rates, the color came off. The color was on my numbers. If you notice on there, I have both the highest and the lowest reoperation rates. I have the highest reoperation rates in young kids and the lowest in older women. Makes it look like this is a biological problem. This isn't operator dependent. This is biology of the disease. The earlier you operate on somebody, the more chance of injury you can operate on them. And I think Shakiba's article is the best with the best data out there. Mine is kind of quasi. And Young's, as you understand, his 47% who had repeat surgery, he didn't see any endometriosis in anybody. But when I talked to him about it, he has no idea whether he can see a 200 micron lesion or not. He has no idea of what I talk about when I was talking about visualization. Doesn't know why he should calibrate his instruments. So when he says he doesn't see anything, I don't know if he knows what he's seeing. If we look at repeat surgery rates, they increase over time. More specifically, most recently, Park Woman has had his go from 11% to 23% to 28% in 10 years. The latest recurrence I had was at 17 years. And somebody whose first operation was 24 years from the last one. Her first one was for nephrectomy for renal death. Okay? And we shaved her rectal endometriosis to avoid a colostomy. And she kept getting recurrences right where we shaved it. So these aren't recurrences, this is persistence of what I left behind. Every single one of them. Not new endometriosis, but old endometriosis. In David's study of his 35 patients who he did repeat operations on, 33 of 35 were in areas he hadn't treated, and most of them, when you look back, you can see what they were from the previous problem. The biggest surgery and David's biggest problem in mine were tunnel vision. Plus, if you just look at the tertiary centers and the quaternary centers, the more deep endometriosis you handle, the better your data looks, and that's the same thing my patients had. Big, large nodules respond to surgery. Diffuse nodules, if somebody has diffuse pain, respond to surgery. The focal endometriosis and diffuse pain is a non-surgical disease. I wish I'd kept the numbers, so I had statistics on that, but that was my observation. If we have time, how's our time? One more little section